Welcome, everybody. I'm Myra Muramoto. I'm the department chair for family medicine here at CU, and extremely honored to be introducing you to our speaker today and tell you a little bit about the Levitt Lectureship. And also tell you we're really trying to get the word out more. We have over 100 people that are registered to join online. We're expecting about 40 people to join us here in person. And we're particularly grateful for those people who have chosen to register outside of our department so that the good work that gets done here and the new things and cutting edge things in primary care can be more widely distributed. So we ask you to fill out our survey at the end. That's really important to give feedback to us. And then pass the word, and you'll have the opportunity to sign up, I think when you registered, to be on the mailing list for future Levitt lectures. So a little bit about the Levitt Distinguished Speaker Series. The history is Dr. Lewis P. Levitt. He was born in Denver in 1896, and he graduated from the CU School of Medicine in 1927. He practiced for 40 years in the Denver area, practiced family medicine, and he gave us a gift to the department of $75,000 to endow a lectureship. And philanthropy is really the heart of the foundation of a lot of the good work that we do, so we're extremely grateful for that. And the purpose is to invite distinguished speakers to share various topics of importance to family medicine and primary care and healthcare in general. With us here at CU, and ideally and increasingly a broader audience across the nation. It's important for us to stay current and educated, particularly in our work as family physicians, but also as teachers and researchers and learners. So that's a key reason for having this lecture series. There will be QR codes at the end here for you to learn more about the program. And answer our event survey. The event is being recorded, as Liz mentioned, and it will be, when it's post-production, it'll be put on our website, so in case you miss it, you can see it there. I also want to add this afternoon at 3 o'clock, our speaker will be joining us for a small group session. If there's anyone who would like to have some Q&A or further discussion with our speaker, you can join us in room 3101 in A01. I'll remind you then at the end. So now I'd like to welcome our speaker, Dr. Susan McDaniel, for giving this talk on improving your communication, will improve your practice, your research, your teaching, and sometimes even your life. Dr. McDaniel is Dr. Lori Sands Distinguished Professor of Families and Health at the University of Rochester Medical Center. She's also the vice chair of the Department of Family Medicine. She's a director of the University of Rochester Medicine Physician Communication Coaching and Leadership Development Program. And she's also the chief psychologist and director of the Institute for the Family in the Department of Psychiatry. Dr. McDaniel's career is dedicated to integrating psychological, relationship, and communication science and practice into healthcare. And I also want to add, Dr. McDaniel has the added distinction of having been in and closely working with, embedded in family medicine as a field for over 40 years. Sometimes I think she knows us better than we know ourselves. So with that, I'd like to welcome Dr. Susan McDaniel.
Thanks for that warm introduction, Myra. And thank you so much to all of you here and those of you online for the honor and opportunity to give the Levitt Lecture this year. For years, you all have inspired me and many around the country with your clinical innovation, your approach to education and your training, your research, your community engagement, your commitment to making primary care the foundation of our country's healthcare system, and the many leaders that you've produced to improve the health of our people. So thank you for your past, your present, and your future work in all these areas. Now, let's see if I can live up to this grandiose title. You all will be the judge of that. Turning to my talk, amongst all we have to consider these days, why should we care about communication in healthcare? Well, because it's associated with improved adherence, outcomes, patient and family experience, and even physician experience. So that's the territory I want to cover today, and in particular, I will share a bit about our context and history. Oops, my slides just went off, and I'm not sure how to get back to where I was. Sorry about that. I wonder if I should use this instead.
You can just use the arrows to advance if you prefer.
Or this, if I'm used to this.
Is that what you were?
Yes.
Perfect.
Okay. I'll use the mechanism I'm used to. So I'm going to talk to you today a bit about our context and history at the University of Rochester, our qualitative research on physician-patient communication, including examples of communication skills that can result in higher patient and colleague satisfaction and improve physician wellness, and a description of our communication coaching and leadership development program that implements these skills. The pilot study used to assess what we need, as well as the program's feasibility, and how to use this program to implement biopsychosocial values and skills across our medical center. And finally, what our current priorities are. Our interest in this area draws on the work of two of University of Rochester's most important pioneers, internist George Engel and psychologist and psychiatrist Lyman Wen, both of whom I was fortunate to work with at the beginning of my career. Engel's biopsychosocial approach and Wen's family systems therapy both derived from the general systems theory that really swept the natural sciences in the late 19th century and the social sciences in the 20th century. My work combines that of these two great men, so I focus on systemic, relational, biopsychosocial health care. I want to share with you how we've applied this approach over the years to various missing elements in healthcare, all of which relate to doctor-patient communication, and I'll use a tree as a metaphor. With general systems theory at the root and biopsychosocial medicine and family therapy at the trunk of the tree, just one second. We've applied this to patient care in areas where we saw gaps. So noting that family members or their natural support system are typically the primary caregivers of our patients, we articulated an approach to family-oriented primary care. Then noting the indivisibility of health and mental health care, we worked on integrated primary care, which led us to noticing how few behavior change approaches included physical issues. So we developed a meta-framework for psychotherapy called medical family therapy, and then focused on integrated specialty care, all of which we call systemic integrated care. As this work continued, we began to study clinicians and teams and the communication necessary to provide patient and family-centered biopsychosocial care. These studies led to more intensive research on doctor-patient communication, and this research then led to me developing the physician communication coaching program. I'm going to just focus on the last two branches of the tree today, but I just wanted to say all this work demonstrates the power of relationships to promote healing for patients, families, physicians, and other health professionals. Fundamental to all this is communication and its complexity in our many types of relationships. As George Bernard Shaw said, the single biggest problem in communication is the illusion that it's taken place. Then there's a great quote by Department of Defense and Pentagon spokesman Robert McCloskey. I know that you believe you understand what you think I said, but I'm not sure you realize that what you heard is not what I meant. Okay, I'll turn now to our qualitative studies on physician-patient communication. I headed an interdisciplinary qualitative research team on 2 National Cancer Center grants headed by family therapist Cleve Shields and family physician Ron Epstein. Our team included an internist, a family physician who zoomed in from Israel every week for our research meetings, an emergency medicine physician, a family therapy student, an undergrad, an oncologist, a family therapist, and myself. I have several studies I'm going to share with you today. All used a methodology that we believe, gave the results of a lot of validity. We used standardized patients who each audio taped first visits with these participating physicians. The participants had consented to having 2 undetected standardized patients come sometime during the year and record their visits from a tape recorder in their backpack. The first study involved, as you can see, 23 family physicians and general internists. And at that time, we were interested in the participants' responses to ambiguous patient symptom presentations. In this case, ambiguous chest pain symptoms, poorly characterized chest pain, fatigue, dizziness, moderate emotional stress. And here we found that these primary care physicians responded to ambiguity by either ignoring the ambiguity altogether or reframing it as if it is unambiguous. As you can see here, 23% of physicians denied the ambiguity altogether. So the patient described these vague symptoms and the physician said, "Your chest pain is caused by gastroesophageal reflux." While 77% of them acknowledged the ambiguity, but coupled it with becoming more directive. Patient, what do you think it is? Physician, I'm not sure what's causing the pain, so I think we should do an endoscopy to see if it's an ulcer or a tumor. Much less often, 3 out of 23 times, physicians responded by acknowledging the ambiguity and attempting to explore the symptoms and patient concerns in more detail. Patient, what do you think it is? Physician, I'm not sure what's causing your pain. It is puzzling. Is there more you can tell me about what you're feeling before we try to make a plan? Okay, I'll turn now to the next data set from which we did several different studies. The methodology was the same, using undetected standardized patients who audio taped first visits with physicians who'd consented. This time, the participants were 19 family physicians and 20 oncologists. The goal of this study was to increase understanding of communication, especially with regard to physician-patient boundaries. And this study built on previous work we did, showing that physician self-disclosure in primary care is frequent and rarely useful to the patient, and on a study done by my colleagues on the team showing that empathy was rare in cancer communication. The subtitle of our first physician self-disclosure paper is my personal favorite, Enough About You, What About Me? I can say more about this study later if you wish, as we didn't find what I thought we'd find, which was a lot of useful physician self-disclosure. In the studies I'm going to share now, the script for the standardized patient was that he had recently moved to the area to be near his daughter. He had undergone previous treatment for lung cancer, but didn't understand that the disease was terminal. He had presented with new pain in the front of his chest, had a chart from his previous physician that was constructed by our oncologist to be standard of care for stage 4 lung cancer. The team reviewed transcripts of the audio tapes and found 4 interesting themes: being patient-friendly versus being patient-centered, blame about smoking, physicians criticizing physicians to patients, and boundary turbulence associated with physician empathy, self-disclosure, and projection. We found participating physicians to be in transition from physician-centered to patient-centered interviewing. For example, they used patient-friendly terms to educate the patient and were almost uniformly caring and friendly. But like I find in coaching, they were more likely to focus on their own agenda rather than eliciting concerns of the patient. The second paper from this study was called Adding Blame to Misfortune. In this study, we found that 76% of 34 encounters of these first visits with lung cancer patients had smoking content. Of these physician comments, we rated 14% of them as supportive to the patient and 86% as unsupportive. So here's an example of a supportive comment. Patient, I've smoked ever since I was a teenager. Doctor, did you quit? Patient, a couple of times. Doctor, it's tough, isn't it? The unsupportive comments, on the other hand, were blaming. Among the 86% of unsupportive comments, some focused on the cause. Doctor, were you a smoker? Patient, yes, ma'am. Doctor, okay, that's our source. And my mother died of lung cancer. Doctor, was she a smoker? We all know there's a link between smoking and lung cancer, but empathy rather than blame clearly is a more therapeutic approach, especially with end-of-life conversations. Empathy allows patients to explore their own feelings about the diagnosis rather than amplify what is often significant self-blame. Our third paper, published in the Journal of General Internal Medicine, is titled Physicians Criticizing Physicians to Patients. In this analysis, we found that 41% of these initial encounters contain comments by physicians about the patient's previous care. Remember that the case was set up with records from the previous physician that reflected standard of care for stage 4 lung cancer. Of the 42 comments about previous care, 29% were coded as supportive and 67% were coded as critical. 4% were neutral. So here's an example of a supportive comment. Doctor, for now I think we'll just sit tight, and I think that the doctors treated you perfectly with what they did, and hopefully you'll stay in remission for quite a while until we have to worry about you. Patient, I appreciate that. The negative comments included criticism of other specialties, criticism of prior treatment, and even criticism of physicians in general. Here's an example of criticism of another specialty. Doctor, did anybody talk to you at all about chemotherapy? Patient, well, I heard them talking to each other at times. Doctor, because the radiation doctor isn't. Patient, they said I didn't need it, basically. Doctor, they're not skilled in that area. Their tool is the radiation machinery. And here's an astounding example of criticism of the patient's prior treatment. Doctor, so he radiated your ribs, not your patient? Yeah. Doctor, that guy's an idiot. Can't make it up. And an example of criticism of physicians in general. Well, you've got to have at least one caregiver. I mean, it's just, you need to make somebody you need to have somebody who's going to look out for you. Hell, you don't want to trust the doctors. I mean, Jiminy Christmas, you know those guys. I don't know. Now, clearly, to be clear and empathic, the setup for this study is anxiety producing for physicians, a patient coming for the first time with end-stage disease who doesn't understand his terminal diagnosis. That's difficult. But handling that anxiety by criticizing the other physician is obviously not helpful to the patient. Our hospital gets many complaints from patients about physicians criticizing their colleagues, which I didn't realize until I asked. Obviously, there are times another physician is problematic, and we need to respectfully help the patient get a second opinion or disengage from inappropriate care. But in this study, there were no examples of physicians disagreeing with prior treatment and then providing information to the patient in a respectful way. Our final paper from this study we call Boundary Turbulence When Delivering Bad News, focusing on empathy, physician self-disclosure, and projection. In a 2010 study, Wang and colleagues found that empathy did not have an effect on satisfaction before surgery, but it did have a very positive effect on satisfaction and patient-reported health status after surgery. In our study, again, we found that empathy is rare, with physicians responding to patient cues for empathy only 19% of the time. Even though rare, both medical and surgical literatures have shown that, physician empathy really does affect patient outcomes positively. Like our earlier study, we found that physicians often respond to a patient's empathic cue with a biomedical question. So the patient said, I was rejected from the military at age 18 because of my condition. They didn't want the responsibility of taking me in, and then they'd have to take care of me for the rest of my life. Doctor, did you have rheumatic fever when you were a kid? Here's another example of delivering bad news without empathy. So this doctor was talking about chemotherapy and said, you know, it might give you a little extra time, but it might shorten it also. That stuff, you know, kills good stuff as well as bad stuff. We have a good one here in town, and I'd be more than happy to have you talk to them, but you don't have a magic bullet here that's going to make all this go away. It's not there. I'll just tell you that up front. They might tell you that they're going to take this away from you, but they're lying to you. So, after doing this study, I read a graphic novel by Harvey Pekar and his wife Joyce Brabner called Our Cancer Year. And to my amazement, virtually all of our main findings are in this book about the couple's experience with Harvey's cancer diagnosis and treatment. Here's their experience with delivering bad news without empathy. The doctor says, I have bad news. We found a very large tumor, so we're simply scooping it out and sewed him back up. Joyce finds herself pushing her fist into her mouth to keep from crying, and Dr. Cantor is talking way too fast for her. I'll come back to their story later. Knowing that empathy is valuable but rare, in doing the analysis of our study, we noticed that physicians do make other, more simple facilitative comments much more frequently, and I thought they deserve credit for that. We called them empathy light. And labeled these categories acknowledgement and affirmation. As compared to the 19% of empathic comments, 66% of physicians responded to patient cues for acknowledgement or affirmation. Here's an example of acknowledgement. Doctor, do you have your family there or were you by yourself? Patient, I have a brother that lives down there and a son. Doctor, brother and son. And affirmation, doctor, what do you do? Patient, I was a manager for a long time. Doctor, you are a busy man. These comments, especially when compared to no response or a biomedical talk, are relationship building. Turning to physician self-disclosure, as in my other study, we found these communications of personal information by physicians are very frequent, occurring in 74% of the encounters we observed, with only 32% being related or useful to the patient. So here's an example of a not useful self-disclosure. Doctor, no difficult swallowing your food? It's going down okay through that passageway because that can also get dry in there after radiation. Doctor, I was looking at your ring over there. Is that? Patient, yeah. Doctor, for some reason I had a chunk of lapis and I'm going to show you. It's about this big and I sometimes carry it in my pocket. For some reason, that color makes me feel better, and I put this on a couple of weeks ago when my sister passed away at age 53, and it hangs down right here at my heart. Every once in a while, I just touch it and go, yeah, it makes me feel better. I just love the color of that stone. And from Harvey Pekar. Harvey has his follow-up appointment with Dr. Cantor, the surgeon. Excellent news about your CAT scan results. The cancer was encapsulated in one lymph node. It hadn't spread beyond that. But before Harvey leaves, the good doctor asks, you told me you bought a house over on Overlook. Would you mind telling me what you paid for it? Because I'm selling one on Euclid Heights around the corner. And another one, we call this kind of physician self-disclosure, I've got it too. The physician is saying, now, if anyone can pull through this, you can. You've got a good sense of humor and you're strong. I went through something like this. I had bumps all over my lungs. It was sarcoidosis, not cancer, and it's given me a lot of trouble. I was very scared at first, but I've learned to live with it. We also noticed transparency, defined as thinking aloud about the illness or treatment, and found 33% of transparencies were coded as not useful, but 56% as useful to the patient. Here's a useful transparency. Doctor, stage 4 lung cancer means it has gone beyond the lungs too. So, patient, I see. Doctor, the radiation may help, and it may help for a long period of time and not useful to the patient. Doctor, so it didn't get bigger because tumors you expect to double in size. Patient, Doctor, it's something that you notice might happen very quickly, something you have to go to the emergency room for, because that could be deadly really quickly if it happens. Finally, we also coded projection, or the attribution of the physician's own ideas, feelings, or attitudes to the patient, and found that 44% of the encounters had a physician projection. Here's an example. Patient, I don't know anybody. Doctor, you don't know anybody here at all? Okay, it is important attaching to support and everything, because if you're going to undergo further treatment for the cancer, you want to not be alone. So maybe you should look for a girlfriend. Patient, well, my doctor, she really takes charge. In addition to describing these categories, we also ran a chi-square and interestingly found that those physicians who made more empathic statements were often significantly more likely to use not useful self-disclosure, useful and not useful transparency and projection. And I see this in the coaching that I do. Many physicians tend to either be pretty buttoned up or empathic but vulnerable to various boundary violations of the kind I described, and we call this boundary turbulence. Boundary turbulence is a term used by sociologist Sandra Petonio to describe situations where boundaries are penetrated. Fuzzy boundaries are at a particular risk in the context of anxiety-producing traumatic events, such as disclosure of a terminal diagnosis. Empathy involves understanding another's perspective or putting yourself in another person's shoes. A seasoned clinical empathizer will reconstitute the boundary, returning to their own shoes and cognizant of the empathic understanding gained in order to effectively and humanely care for the patient. Boundary turbulence occurs when the reconstitution doesn't happen, as reflected in our data. Oncologist Tony Back said of the need for communication training for physicians, "We already knew how to be nice. What we didn't know was how to integrate an enormous amount of biomedical expertise with the lived experience of individual patients." And I agree with this. Our studies reveal that boundary management should be included in communication training for all physicians. So I hope you can see through these qualitative studies how important physician-patient communication is to patient outcomes and satisfaction. With this in mind, I'm going to turn to the Physician Communication and Leadership Development Program, where we work directly to create a culture of feedback and wellness using relational systemic principles in order to enhance the elements of communication and self-awareness that are part of lifelong learning for all of us. So we developed this program based on the studies that we did and the need that we saw because of it. Dr. Keisha Bell, one of our coaches who's embedded in OBGYN, described the goal of communication coaching as seeing patients accurately and intentionally and seeing ourselves accurately and intentionally. Just as I was starting to run the pilot for our communication coaching program in 2011, Atul Gawande published an article in the New Yorker called Personal Best on procedural surgery, coaching and surgery, saying, top athletes and singers have coaches. Should you? He went on to say, no matter how well-trained people are, few can sustain their best performance on their own, and that's where coaching comes in. The development of our program, as I said, began in 2011 to 12 when I needed a systems-wide project for the ELAM Leadership Development Program that I was part of representing URMC. And Dean Taubman asked me to develop something to help with patient satisfaction in response to patient complaints, as well as the fact that patient satisfaction was soon to be a driver for hospital and physician reimbursement through patient satisfaction surveys of inpatient and outpatient care. So that was the genesis of the program. After reviewing the literature, I selected the Calgary-Cambridge Observational Checklist to code physician communication because its elements are correlated with both patient satisfaction and quality outcomes. The pilot and the subsequent program are based on the checklist of 30 communication behaviors, and I added 7 items based on my own research about communicating with family members and recognizing patient and family affect. So I developed a process that includes observation of physicians seeing patients for at least 4 hours to get a valid sample, then compiling both the quantitative and qualitative data, writing and sending an extensive detailed report that paints a picture of the physician as communicator, and then meeting with the physician to debrief the experience and discuss both the strengths and concrete behavioral recommendations for improvement. After developing the program, I ran a pilot to understand what our physicians at Rochester need and to check for feasibility of the program. I included 2 groups of physicians from a variety of medical specialties. We had 6 surgeons and 6 non-surgeons, 6 with high patient satisfaction scores and 6 with low scores, and it just turned out to be 8 men and 4 women. And I watched a total of 75 physician-patient encounters. For the pilot, I used 3 of the communication skills felt to be important by a focus group of 40 physician leaders. They are I for introduce yourself in your role, C for ask about patient and family concerns, and U for check for understanding. And I was hoping people could remember this, but through the acronym. Starting with introduce yourself, I found that our participants introduced themselves 81% of the time. Of course, that means 19% of the time they didn't, but in particular, non-surgeons and females introduced themselves 100% of the time to new patients. Sure, that was a coincidence. Anyway, but in perhaps the pinnacle of my career, I had a friend at this time text me to say they were attending the taping of the radio show, Wait, Wait, Don't Tell Me, in San Francisco. And there was a question based on the publication we just made about this, as well as one from Johns Hopkins that looked at communication by internal medicine interns. So ours was on faculty, theirs was on intern. The question they used on the radio show was, how many physicians tell you who they are before getting into your business? And there they used the percentages from the interns, because I think it was more provocative than 81%, so that the possibilities were 27, 40, and 51%, and with the interns, the answer was 40%. So I took that actually to mean this does really matter to the public about something that seems simple. In terms of asking about patient and family concerns, I found our participants did that 72% of the time, which of course means 28% they didn't ask about patient concerns. Physicians with higher patient satisfaction scores were 10.6 times more likely to ask about patient concerns. I'm going to show you a couple of bad illustrations of these behaviors from the 2011 movie 50-50. It's written by a filmmaker who had a brain tumor in his 20s with a prognosis of 50-50. And I recommend the movie if you haven't seen it. This is an interaction of the main character with a physician when he found out about his diagnosis. Notice whether the physician tends to the patient's concerns in any way.
Hi.
Patient has been complaining of back pain and night sweats. Blood tests and urine analysis are normal. MRI suggests a massive intradural malignant schwannoma neurofibrosarcoma extending into psoas muscle with nerve root compression syndrome and bone erosion. Growth extends from L2 to L5. We'll send patient for biopsy to confirm. Yes, question.
Sorry, I didn't follow that. Is there something wrong with me?
Yes, well, if you look here on your MRI, you see this cephalopod-like object that's spreading down your spinal column. That is a massive schwannoma neurofibrosarcoma.
Okay, So sorry, I just don't know what
It's a malignant tumor.
A tumor?
Yes.
Me?
Yes.
that doesn't make any sense, though. I mean, I don't smoke, I don't drink, I recycle.
Actually, your case is really quite fascinating because your cancer is the result of an incredibly rare gene mutation in chromosome 17p and the p53 gene that causes the growth of platelet cells. It's good that we've caused for neurosis. In your case, it's your lower down to the 4-month regimen of chemotherapy is a very aggressive dosage. So you might want to get you through the course of lowered. I think that given the placement and size of your particular tumor, the wisest course of action is to see if we can possibly reduce this thing down to a more manageable size before we consider surgery. Now, chemotherapy can often result in fertility issues.
But I'm going to be okay.
If you need someone to talk to, we have an excellent staff here at the hospital of social workers and psychologists. They specialize in these matters, and they would be able to help you.
Okay, so this clip well illustrates the effect of anxiety on patients' ability to hear, even if the physician does a better job than this poor man did. It also shows us a physician who's much more interested in talking than listening. I do want to emphasize that it's not only what we say when interacting with others, but how we listen. Many communication skills are in the service of listening. In family physician Ron Epstein and general internist Mary Catherine Beach's patient focus group on listening, one patient said, oops. I don't want to play it again. I want to advance the slide. Here we go. I don't need your pills. I need your attention. And on the other hand, commenting to a physician who was listening, you're listening to what I'm saying to you, not just hearing. There's a big difference between listening and hearing somebody. You can hear a noise and not pay attention to it, but if you listen to it, you can figure out what it is. So that's what I want doctors to do, listen to what I'm saying. And So Stephen Covey of 7 Habits of Highly Effective People talks about why effective listening is so difficult to achieve. And I think it's true that most of us don't listen to understand. We're busy thinking of what we're going to say next. Okay, returning to our study, and the final skill from the pilot was check for understanding. We know that patients do less than 50% of what physicians or other clinicians tell them to do. So what's going on? Why is that? Research shows that patients remember and understand less than half of what we explain to them. And because of this, AHRQ said that patients in recall and restate, we need to ask patients to recall and restate what they've been told, and they made it one of 11 top patient safety practices based on the strength of scientific evidence. The study also, there are studies that show that this affects outcomes. Physicians' application of interactive communication to assess recall or comprehension was associated with better glycemic control for diabetic patients. So, in terms of what's universal, everyone benefits from clear information. Many patients are at risk of misunderstanding, but it's very hard for us to identify them. Patients often won't ask. And testing general reading levels and even education levels doesn't ensure that patients understand in the clinical setting. So, asking patients to demonstrate understanding, lots of times physicians will say, well, I don't know how to do it without sounding condescending or as if the patient is dumb. So my suggestion is, it's on us. I want to be sure I explained everything clearly. Can you tell me what you understand about your diagnosis? Or tell me what you'll tell your wife about our visit today. What is your plan about taking your medications once you get home? Taking 1 minute to check for understanding can surface misunderstandings or disagreements that can prevent a treatment plan from succeeding. But as with other studies about check for understanding, this really didn't happen much with our participants. I found only 23% of them checked for understanding. Female physicians were 6 times more likely to do it. So with this study in mind, I want to share one more brief clip from 50/50 that illustrates a surgeon talking with a family after the surgery without any attempt to connect or check for understanding.
Mr. and Mrs. Lerner. So, as you can imagine, with a surgery of this magnitude, there were some unforeseen complications. The bone erosion was much greater than initially anticipated. We had to remove part of the hip and pelvis, as well as most of the right psoas muscle. We also had to remove a good amount of the sheath tissue around the sciatic nerve. It's not going to be an easy road back, but he's going to be okay. He's going to be okay.
We should start with that information, okay? That should be the first thing you say. Good.
He's going to be okay. Thank you, doctor.
So you could see Josh Rogan doing some useful communication coaching for that surgeon. And I do want to say that just as it's important for physicians to check to make sure they're understood, it's also important to demonstrate through reflection that we heard our patients. Because without verbally recognizing what the other person said, it can be impossible for the patient to be sure they were heard accurately at all. Additionally, people often don't change until they feel understood. So, the physician's performance on these 3 ICU scores predicted whether they were in the high or low patient satisfaction group to the P.0001 level, which was a little surprising given how small the study was, but there we go. So after it was clear that we're onto something here, the dean wisely told me the next step was to coach the senior associate dean for clinical affairs and all the chairs of the clinical departments. So here I am with Senior Associate Dean Ray Majewski, who loved the experience, saying no one had observed to give him feedback in 40 years since he had worked with George Engel. And he wasn't the only person who loved the experience. These are long-term patients of Ray's who were so thrilled about the program, they literally begged me to have their photos taken, showing them fully, and insisted their pictures and feedback needed to be part of the presentation. So here they are. This is representative of what outpatient coaching looks like, me sitting quietly, observing the interaction, and writing furiously on my clipboard. Some of our younger coaches do use computers. And here I am in the debrief session with Ray after I'd sent him my detailed report. My assistant always sends out an anonymous survey monkey on all our coaching sessions, and so this was my very first one on the pilot. And I was pleased to see that 60 of the participants found the experience very helpful, and only 40%, and 40% found it helpful, but no one endorsed neutral or not helpful. And we often get useful comments as well, and here are some from the pilot study. She showed me all the things I was doing correctly and pinpointed some areas that could be tweaked in the future. I think every provider in our department should meet with her. I believe this type of experience is valuable since habits, good or bad, creep into communication. Very professional and insightful. I would like to do this again. She made me realize that I did a lot of teaching but didn't always elicit patient concerns. Her comments were very objective and specific. And my personal favorite feedback, very helpful indeed, even though it was truthful. So in the early years of the coaching program, faculty started to get interested in who could be a coach. My talented colleague, psychologist Lauren DiCaprio-Ryan, was starting in surgery as the first embedded coach in a department after she finished her fellowship training with us and joined the faculty. And she soon became a Macy's Foundation Fellow and needed a project. At the department's urging, she developed a study where we coached surgeons about how to coach each other on their communication. Honestly, I was skeptical about this. Oops. But we decided to do it because that's what research is for. So 12 faculty participated in this pilot in which we included a didactic session that introduced them to key communication behaviors, how to identify and code the behaviors in real time, and how to give constructive feedback. The didactic session was interactive in nature, with surgeons watching and coding clinical scenarios that ranged from bad to ideal, talking about how they would give feedback and role-playing giving that feedback. They worked on how to focus on the communication rather than the diagnosis. For the sake of time, I'll spare you the analyses and the statistical details, but long story short, it didn't work. The surgeons had a very hard time coding behavior and not giving advice to their colleagues. It was something like this. Al finishes reading his report on Frog. The end. So any feedback? Frog, I didn't like it. Al, any constructive feedback? Frog, would you consider it wasn't very good, constructive? Al, not really. Frog, then no. So we now have 2 psychology faculty who are embedded coaches in surgery, and they're well appreciated. So if we're not training peers as coaches, who are our coaches? They are primarily psychologists, though we have trained some family physicians and psychiatrist faculty to be coaches. What we look for is behavior change expertise, medical educator experience, and psychotherapy skills that are helpful for addressing wellness issues, and also understand how to make a referral, mental health referral, if that's what's needed. Here's some of the comments by our psychology postdocs who are part of the Coaching Academy. My training allows me to think systemically. What are the contextual factors that could be influencing this resident's presentation today? And to appreciate the developmental process of learning complex skills. And being in a profession in which carefully choosing our words is one of our most powerful tools, uniquely positions us to provide guidance around communication. Additionally, our knowledge of behavior change and systems thinking is instrumental in being able to provide structured, developmentally appropriate feedback and understand various behaviors within the larger context. So it's now a popular program after 12 years, with leaders frequently using our senior coaches to help their faculty, and many residency programs embedding our coaches in training to educate their residents. Here's where you'll find our coaches. Both the faculty and the resident coaches have mushrooms, as I said. We have embedded part-time coaches in 13 departments, all the green boxes. The core of what we do in resident education is to work on improving the patient-family experience and enhance learning regarding a biopsychosocial approach. The blue boxes are areas of the medical center that routinely ask for our help with faculty or have requested an embodied coach in the future. In these spaces, our coaches are not only following the standard model of observation and feedback, but also supporting efforts that promote physicians as leaders, facilitating bidirectional feedback between faculty and learners that include difficult conversations, and building a sense of teamwork. Most importantly, each of our coaches tailors the work that they do to the departmental culture they're in meeting the needs of the local system and learner environment in order to promote the success of the trainees, faculty, and staff. So I want to focus just for a few minutes a little more on what we do in the residencies now, using surgery as the content, though the process is similar across disciplines. So let's begin with how Lauren started in surgery. She spent the first month shadowing residents and faculty in a number of contexts. To join these teams required arriving at 4:30 a.m. rounds with the junior residents. She quickly discovered that no one's particularly interested in best practices in communication at that time, and most people are barely awake and the coffee shops aren't open. Residents were initially cordial, though trepidatious. Early on, one said to her, "You are terrifying," which this description would come as a surprise if you knew Lauren. This resident and others began to say that having their communication skills observed meant they were being evaluated in yet another skill with minimal training. Ensuring they could see the process as formative rather than evaluative became critical. It also meant that residents needed to see their faculty participating in coaching to normalize and champion the process. It took a while. At an early division morbidity and mortality conference, for example, someone said, "Shh, the psychologist is here. Best behavior, everyone." Of course, if they could demonstrate good communication, then it meant they could change behavior and ideally sustain it. However, moving from Lauren observing to Lauren coaching took time. Not infrequently, a resident would say, "I don't need coaching, thanks though." But by the time they received their personalized report just for them and had a debrief, she, as is true for me in my experience, had a hard time containing the debrief to an hour. Many residents would say, "No one has ever given me this level of feedback." And it became clear that through traditional approach of silence was not a desirable method of feedback, and that role modeling in this domain isn't enough. So currently, Lauren and I and our newly graduating fellow psychologist, Holly Weldon, are looking at how the clinical learning environment substantially influence the resident's role, the communication skills they demonstrate, and those that are needed in these various environments. So we're looking at how these residents function, what they see as their responsibility, and what faculty expect of them. We notice that the environment also influences the stressors they experience, including patient volume and acuity, and the need for routine debriefing. And we saw a link between professionalism and well-being that needs addressing. To understand this more, we looked at communication skills in trauma and acute care, in the general surgery rotation, and in pediatric surgery. You can see that we observed 24 residents in 373 interactions across these three contexts. We looked at the same residents' behavior across all three settings and found it to be different in each place. The most common communication skills we know to be influential to patient satisfaction and outcomes were observed in the pediatric surgery rotation, slightly fewer on the community and general surgery rotation, and substantially fewer on the trauma service. Notably, in trauma, they introduced the team more often as compared to general surgery. And while the pragmatics of sharing next steps was something the residents did relatively consistently across all the settings, the capacity to respond to patient cues for empathy varied tremendously with statistically significant differences. Our next step here is to determine which communication skills are important across contexts. Lauren thinks most are, and which are context specific. Surgery residents, like others, frequently complain of lack of adequate time to slow down and connect with their patients. But feedback from residents revealed other factors that contributed. And here are a few that illustrate the complexity. For one, there are personal and family factors. A resident said, "When I walk into peds, I see the faces of my own children. It's easier to ignore the kids and focus on the parents or get to the OR and call it a day." And another raised the important point that faculty themselves had not been trained in communication practices. This same resident went on to reflect their awareness that faculty are not all trained medical educators. He said, "I know patients have to trust us, but I don't want to connect before surgery. I need to be able to cut them open. I'm not going to sit down and have conversation first and who they are. I'll get to that later. And I trust my faculty to teach me in the OR. I know that I will graduate and be able to operate safely, but I'm not sure they always know what to say either. We don't have consistent role models." So we know that things have changed over time. Behaviors that were once tolerated in medicine and certainly surgery are no longer okay. And surgeons from increasingly diverse backgrounds are entering the workforce with different learning needs, communication styles, and expectations regarding what creates a psychologically safe and effective teaching environment. Not infrequently at the faculty level, we're dealing with professionalism issues. Studies show these problems are very costly to patient care and clinician satisfaction. Patients who reported unprofessional communication behavior or behavior by their surgeons had 14% more complications in the month after surgery than those who felt their surgeon treated them with respect, in an 27 article by Cooper and colleagues. And these complications included surgical site infections, pneumonia, kidney conditions, stroke, heart problems, blood clots, sepsis, and urinary tract infections. Hickson said, "We need to reflect on the impact patients and families experience from these avoidable outcomes. From conservative economic estimates, the cost of addressing the excess surgical complications could amount to more than $3 billion annually." These physician researchers conclude that improving physician communication can improve patient outcomes. The authors state that the goal for the interventions with these surgeons, much like the goal in our program, is to develop insight and learn to self-regulate. A very similar outcome seems to occur when it is parents of neonatal intensive care unit babies who are rude to the medical team. Bamberger and his team at Tel Aviv University used simulated crisis scenarios to train and study medical staff performance. In these scenarios, the actors who played the parents were rude, but not angry. As Dr. Bamberger said, they weren't going ballistic, they weren't violent, they just said things that weren't so pleasant for the physicians to hear. For example, one mother said loud enough for the staff to hear, "I knew we should have gone to a better hospital where they don't practice third world medicine." When parents are rude to a pediatric intensive care team, Bamberger found, individual physician, nurse, and team performance deteriorates, including diagnostic skills, procedural skills, and team communication for the rest of the day. Like my earlier study, this same research team studied scenarios where a physician was rude to another physician, especially in the OR. The teams then performed significantly worse in the simulated patient emergencies. Their diagnostic skills and procedural skills deteriorated, as did ordering and giving the right medication. Both doctors and nurses performed worse individually and were less effective as teams in terms of communication and helping one another with the patient. Bamberger's hypothesis is that even with mild rudeness, people need to expend cognitive resources to deal with the threat, resources that can draw away from teamwork and the task at hand. "We are human beings, we're affected by rudeness," he said. All this can also affect patient outcomes, and that's why we developed the coaching program. So to summarize, our program is personalized, evidence-based, and helpful to the most as well as least experienced physicians, those with the highest patient satisfaction scores and those with the lowest. It's a program that promotes a culture of support and feedback throughout a physician's clinical career. We now think about our program as multifaceted, as you can see here in this graphic. Here are the various aspects now of the program, starting with the standardized observation for faculty, residents, students, teams, and researchers in the range of clinical and other settings, acute, patient ambulatory, the ED, the OR, research labs, using all the tools that seem appropriate. It inevitably involves leadership development, including increasing self-awareness and self-regulation, professionalism, mindfulness, systems thinking, context and situational awareness, and anti-bias training. In collaboration with the Office of Equity and Inclusion, faculty development, behavioral health partners, and EAP, as well as our WellU and the occasional involvement of external coaches. We're committed to growing the coaching program through our coaching academy, focused on dissemination and evaluation of the program. And honestly, at this point, we have more demand for our services than trained coaches' time, but we're working at it. So this gives you some context for the current program. You can see it's grown a lot. The priorities at this point are continuing to emphasize the importance of ongoing work on communication as a key and complex skill for physicians, which means ongoing attention for all faculty, especially leaders, new faculty, low-performing or disruptive faculty with professionalism problems. We focus on training our new coaches embedded in residency programs during their 2 years, 1 day a week. And we're really working hard with CJ Peak and Frank to articulate the essential elements of the program as we think about its implementation elsewhere. So one of our coaches early on said, "The idea that we all have blind spots, don't know everything, are constantly missing things, can improve our practice in critical ways, and most importantly, can learn from others who are not of the same discipline. One could say that coaching is subversive in a good way, to the dominant culture of the disciplinary silo. We're working to create a culture that welcomes rather than avoids feedback. And we're convinced that altering longstanding communication habits that are continually reinforced by medical culture is no small task, but it is possible and it's very rewarding. That being said, even the youngest patients understand what it's needed. Believe it or not, a couple of weeks ago, our daughter, who lives in DC, we live in Rochester, and she and her husband are not in healthcare, but she found a drawing on the bedroom floor of our 6-year-old granddaughter Ansel's room. And here's her drawing, which I think can serve as a summary for my talk today. A doctor must be patient, a doctor must be kind, a doctor must be loving, a doctor must be giving, a doctor must be forgiving, but most of all, a doctor must be a doctor. Thank you.
Thank you, Susan. We'll now take questions in the room. So please feel free to raise your hand and Lisa will come greet you with the microphone.
Larry.
Wow, that's terrific. Thank you very much. Would you mind saying more about avatars? I saw that go by on a slide. How are you using avatars?
So I couldn't hear that very well, but I think you're asking about avatars and communication training. Is that what you're asking? Yeah. Okay. So Ron is doing some studies about that right now with our various computer science people. And I actually don't know about the studies that are out there that sort of definitively show what we can use avatars for, and what things it works for, what is not so good. I did, for 6 years, I was on the board of advisors for the Duke School of Nursing, and they were really introducing a lot of avatars. This was a good while ago in their training, and I saw how creative it could be. It's hard for me to believe it's quite the same as a real in-person interaction, but there's a lot of foundational skills we could all practice. Avatars. Do you know of any studies? You do? Okay.
Thank you so much for your presentation. I had a question about the coaching academy and the training involved in creating coaches. How is it set up, over what period of time, things like that?
So it's 2 years, 1 day a week. We spend several months first, and we don't use avatars, but we do have some good. I made some videos with the chair of the Department of Surgery, who's a pretty good communicator, so that they could learn to code scenarios that were good and some that were not good. And so we work pretty intensively with people. After that period of time, so they usually start in August, around November, they're assigned to one of these departments who, actually the departments pay for a day a week of the fellow's time to do this. So that's how we fund it, whereas the faculty program is funded by the medical center. And it's worked out really well. So they go in, we oversee their report writing, discuss what they're seeing, help them learn to code. We try to only put people in the coaching academy who are already pretty good at behavioral observation and self-aware enough to know when they might be projecting rather than seeing what's happening in front of them. So there's a certain set of skills that need to be there before we start this. But they spend 2 years learning to write the reports. We review all the reports and use that as a way to, early on, we actually go with them and watch them while they watch the coachee do their thing. But by the end of the first year or so, they're getting the hang of it, and the second year they really advance their skills. for the people that are most talented, we certainly try to hire them and then put them in one of these departments that wants a faculty communication coach.
Do you have a follow-up question, Cleveland? Darn.
Hey, Deb.
Hi, Susan. I'm so happy to see you.
Yeah, likewise.
Just thank you for the talk, and you need to know that what the medical school does in terms of communication skills training has more than something to do with the mentoring you've given myself and others in our departments.
That's very nice for you to say.
So I think Cleveland is one of our coaches right now. Do you agree? Yeah, I can't wait to see you at 3 o'clock. Two things, a question and then a comment about avatars. We did experiment here with a program, it was maybe 4 or 5 years ago, I don't remember it, specifically geared towards learning, our med students learning communication skills through interacting with goggles, full virtual reality experience. And I played around with it, a number of us on the team did, and we flatly rejected it with the primary, it followed Calgary, Cambridge, and Kalamazoo. It knew some things, but our biggest concern was it was actually going to reinforce superficial empathy, just plain acknowledgement, as opposed to the other levels of empathy that we know, and we didn't want to reinforce that at all.
Yeah.
If I can think of the name of it, I'll tell you, Larry.
That's really interesting to hear, Deb. I will say that we do really try to teach people to take the physician or the student or the resident where they are. And there are definitely some physicians who don't say anything after ask a question, the patient answers, then they ask the next question, then the patient answers. And for those people, I do think teaching them acknowledgement is a big move, and making sure they consolidate that skill. Once they've done that, which I think takes a month or 6 weeks, then we might go back and teach them affirmation. Empathy is, ideally you ask the patient how they're feeling and then you reflect their feeling rather than imagining yourself how they might be feeling. So it's a complex, advanced skill that I think requires being in pretty good touch with yourself, which, not everybody is.
Yeah. We actually separated out reflection and empathy as two separate skills.
Absolutely.
And the learners can get reflection much.
Yeah.
Actually, even our standardized patients confuse empathy and reflection
Right.
In assessments. So here's my question, going to the very pecune. You all talk about asking about concerns. And some of the rubrics reference that as setting the agenda. And I think they're really different skills. And we've gone with setting the agenda, but I'm wondering what your thoughts are about those differences and the whys and wherefores of what to teach.
So those were only 3 of the 37 skills that we code, and just pulled them out because we needed to make it simple enough to actually do the pilot study and check for feasibility. We do code for setting an agenda, and we do talk about, if the physician has something on their mind they want to accomplish, to say so, then to ask the patient for their concerns, and then to explicitly set an agenda for the visit so that you don't have, the end of the visit hand on the doorknob problem. Or other just times, I can think of an experience I had as a patient where the physician got so involved in telling me about his trip to Italy. I like this physician, but I forgot one of my 2 main reasons I went to see him, because I was busy thinking, don't you have a patient to see? We could talk about this at a cocktail party. So it's just, that can be distracting. And I realized he didn't set an agenda, and I forgot to do it when I was in the patient role, so.
And you to ruminate on in-room questions, I'll ask the one that we have online for you as well. First of all, I want to say that you've received gratitude online for just expressing this program. They've said it's wonderful. The question that I have is multi-part, so please feel free to let me know if you want me to repeat any of the parts. But it says, to what extent are doctors interested in participating in the coaching program? What motivates them to participate? do they apply their work with patients, do they apply their work, like this communications knowledge to their patients, and do they share their successes after applying these skills and the knowledge that they gained?
Okay. You can prompt me when I forget one of those. Okay, the first one was, do physicians want to do this? And on the whole, I would say, absolutely not. Why do I need to do this? Because I'm a great communicator. I mean, I get that. I feel that way. But we're really not very good observers of our own behavior. People come to us in a variety of ways. At Rochester, they have to participate in some training to get malpractice reduction, and our thing qualifies. And sometimes they've done a few of the things that were already offered, and they thought, okay, well, I'll sign up for this. Sometimes they hear from their colleagues that it's valuable, and they seek it for themselves, and that happens a fair amount of time. And sometimes these people are referred by the CMO or the Senior Associate Dean for Academic Affairs for, quote, professionalism problems. So we see many of the professionalism problems that the Faculty Professionalism Council decided needed intervention. So the leaders for that group, the CMO or the dean will write them a letter that says, you really are terrific at blah, 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 and the Med Center values what you have to offer. This thing, the complaint that came in where you blah, 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 you can't do that anymore, they say in some professional language, and that's not what we're about. And if you do it again, you won't be reappointed. However, we're going to give you a free trip to see Dr. McDaniel, and she knows how to help you be successful. So that's how, I don't know, a third, maybe more than that, of the faculty coaching that we do get to us. So you can imagine that they are, first of all, thinking, yeah, right, this isn't going to help. And I don't have a problem anyway. It was this other person who complained, their fault, et cetera, et cetera. But that's fine. I mean, we're used to that. It's okay. But I think we're pretty good at, we put them through the usual thing. And I tell them, look, you're fantastic. You need to change. And yes, you've done it for 30 years, but now it's not okay. But we don't want you to leave medicine, with this as your legacy. And besides that, you've done harder things. You can do this. So some of it's cheerleading about you really can change. And a shocking number of people really do substantially change. Their jobs are on the line, and they're reluctant, but in the end, they actually are very appreciative. And it's not all that uncommon to say, my wife said to tell you she really appreciates what you're doing. Because they apply the skills other places besides just in the OR or in the outpatient clinic or whatever. Did they talk about that it was successful? Was that one of them?
So essentially the last part was, how do they illustrate their successes, after the fact, or how do they come to understand them?
I think that most of them get much more comfortable about the fact that it's something we all need to work on, and they talk about it, especially with their trainees, and they encourage their trainees to participate in the training. And they're grateful to us. Lots of times it actually is more difficult to get them to detach from us because, they're getting support and they feel like we really know them. I think our reports that are quite lengthy and detailed make the physicians feel seen in a kind of existential way. And so, that's support that they don't usually get. So when we can get them to say, we're here, and you can call on us, but we don't need to meet every time, then that's what happens. And a lot of people will just write me and say, I'm still doing great, and blah, blah, blah. And sometimes we send people to therapy. Very occasionally we do work directly with the therapist if the coachee wants us to. And the report is just for the faculty member or the resident, but if they were referred for a problem, we talked to the coachee about what we're going to say to the dean or the CMO. And by then, there's some agreement about this is improving, this still needs work. That's all we say. We don't give the report to the leaders.
Are there more questions there? In that context, have you ever used the secret shopper patient methodology?
Say it again?
It's the secret shopper patient methodology.
You mean that we used in the
Like
research?
a spy patient, yeah, have you?
When I go to the doctor, you want to hear a story? Okay. So, I don't know, 2014 or 2015, I had to have a colectomy, and I was in the hospital for a good time. You know, I was miserable, and I looked the part. And for 3 days, nobody asked me anything about myself. My husband's a physician. He's in there with his white coat. That didn't matter. It was, you know, it said faculty on the door. That didn't matter. It didn't seem to matter. Nobody asked me anything. And after 3 days, Betsy Nomberg, who is a family physician on the faculty, but a good friend of mine, was in the room visiting. And some surgery residents came in, and she was an advisory dean in the medical school, and one of the surgery residents was one of her students, and very good. And so he says to her, "Oh, are you her PCP?" And Betsy says, "No, I'm her friend." So then that was confusing to the residents. So they must have gone back and read my chart, which apparently nobody else had. They kept calling me Mrs. McDaniel, and which was my mother to me. And she had died a few months before, so it was like not great. And so anyway, the residents come back a couple hours later after looking at the chart, and they said, "You're a psychologist?" I said, "Yeah." And they said, "Do you work at the medical center?" I said, "Yes." And I don't know why they said this, but they said, "Do you do research?" And I said, "Yes." And they said, "On what?" And then I thought, okay, the first time in 3 days, I'm enjoying myself right now. So I waited a long time and I said, "On doctor-patient communication." I felt sorry for them. The intern turned red. The junior resident just looked at his feet. But the senior resident, who Betsy had told me about, was really good. Like, in a split second, he said, "Would you give us feedback? Because nobody ever does." And I said, "Sure, let me think about it." I mean, that was impressive. So they leave. I think about it. Meantime, my daughter comes from New York to visit. And so the next morning, she's sitting in the room when these people come in. The residents, they walk in and I say, "I have some feedback for you." And my daughter's like, "No, Mom, no." I hadn't mentioned this to her. So they said, "Oh yeah, what is it?" You know, so I said, "You did such a great job. You asked me about myself." I pointed out all the different things they did. And I said to them, and I actually said it to some of the faculty, I said, "You know, I'm doing grand rounds in surgery fairly soon." You know, and they were like, "Yeah, right, lady." And so, long story short, the first day I was back, after 3 weeks, I gave grand rounds in surgery about this stuff, about the studies. And it was so great. So they all my team, along with everybody else, comes in, and especially when my team, I'm going, "Hi, hi." And they're like, "I have no idea why this woman looks like she knows me." None of them recognize me at all. So I did the first half of my talk, and then right in the middle, I said, "You know, and I want to tell you a personal story. 3 weeks ago, I was in Highland Hospital because I had blah, blah, blah." Like, the audience is like, "Oh my God, wait, was I attending them? Wait. Because I told the story about how they didn't, you know, ask me anything, and about how these residents did. And I'd seen the residents come in, especially this guy came in too, also didn't recognize me. And he's up at the top. And then I flashed up a slide with his name real big and said what he had done, so he was mortified, but it was good. It was good validation. So we have intentionally occasionally used a secret shopper more in the clinic, telling everybody we're going to do this, and looking for a variety of things, not just communication, but other quality metrics. But as coaches, we do talk about, my colleague had a baby with a big-time problem when they delivered, and she was in the NICU. So she was exposed to, anyway, we now have embedded psychologists in the NICU. There's, any place there's a lot of anxiety, it's tough. It's tough to do the right thing. Yes.
Hi, thank you so much for your wisdom. I'm a psychologist working at an integrated family medicine care clinic. I recognize your research is on doctor-patient communication. I was wondering if you're familiar with any resources I could access for basically doctor-team communication. My goal is to help my clinic move from a siloed, co-located environment to a more integrated, cohesive, team-based clinic, and I feel like we're kind of halfway there. We're still running into.
Good.
Yeah, it is good. We're farther along than we were 2 years ago.
So some of it, I think, is structural. How often does your teams meet together?
We have an all-staff meeting once a month, but seems to get canceled.
It's different.
Seems to get canceled quite a bit.
So working on team dynamics is very helpful. If you do have some regular meetings, we actually meet in our teams weekly in family medicine.
Weekly.
And once a month, we have all staff, all 130 people together to do team training collectively.
Okay.
But I do think team training, there's a American Psychologist Special Issue, somebody mentioned it to me, a family doc, before I started my talk, where Eduardo Salas, who's a team scientist, and I did a special issue trying to look at all the different studies that have been done about what predicts effective teamwork. And it's clear that team training is what predicts effective teamwork. Team building is nice, but doesn't predict the outcome, but team training does. So you need some places to be able to do that periodically with the people you actually work with. And I think you can provide some good facilitation and suggestions, but there has to be kind of a shared mental model about it with the leadership and an interest in team effectiveness and what really makes us good at stuff. And there are interesting things like, for example, huddles are great. Do you do huddles? Not so much.
They don't go well.
If you're not, okay. If you're not sure it doesn't go well, then you can work on huddles. Huddles predict, better outcomes. But even better than huddles are debriefs. And debriefs are difficult in primary care because the staff all leave at different times.
Right.
But I did a study while I was working with Eduardo using phones. We had a simple survey monkey about people's experience of the afternoon or the morning session. What went well, what didn't go well, what suggestions do you have? Everybody filled it out, took about 30 seconds at the end of their shift. And then I would go to the team meeting at the end of the week and present, here's what we said we're good at, here's what we said we're not so good at, here's some suggestions. And I will say for us, and I see it a lot in the medical center observing, the thing that came out that people really had a lot of trouble was conflict. They're just avoiding conflict right and left. So then we did some training around that. I actually used something that Frank used when we were working with all Colorado integrated primary care integration. There was an exercise that I then did with my team about what people learned about how to deal with conflict in their families, and it was incredibly helpful. And then people really they wanted to be able to give feedback on the session. They wanted to be able to talk about it, and then you're starting to move towards a different level of team functioning. But it takes time, and if you think you're 50% there, that's good. Then it's like, what's the next step that the leadership can buy and support?
Thank you so much.
Do we have any more in-room questions? All right, if that's the case, I'm going to hand it over to Myra to close us out.
Thank you so much, Susan, for a really thought-provoking and interesting, inspiring talk. I want to thank everybody in the room for taking your time to come and listen, and thank everybody who's online for also taking the time and joining us. Most of all, I want to thank Susan for taking a trip out here and really sharing all the amazing work she's done and what she's learned, and help us do better in the things that we do. I do want to remind people, for those of you that have time, that at 3 o'clock that Susan's going to be over in AO1 in room 3101, fielding questions, continuing discussion. So if you have the inclination and time to join us, please do. Anybody can come. And with that, we'll release you to the rest of your day. So please, a round of applause here.
Thank you.